So in the entire segment, we had discussions on the updates in the GINA guidelines and then the ERS ATS guidelines that came out. My talk was trying to take all those guidelines and highlight some of the challenges that we may see in clinical practice and trying to implement those. One of the big changes, and we'll get to this in the GINA guidelines, was the talk of doing a single maintenance and reliever inhaler with an inhaled corticosteroid and formoterol. I spoke a little bit about some of the practical challenges in getting insurances to pay for a single inhaler that's both a maintenance and a reliever inhaler, and some problems that patients have had getting those refilled early. And then we spent the bulk of the talk talking about how do we make decisions in our patients with severe asthma, because there's certainly a paucity of data of how do you choose a non-biologic option for versus a biologic option. And then if you qualify for multiple biologic options, how do you pick which biologic is best for your patient? How do you assess that it's working? And then how long do you keep them on it if it is working? The big gist of it was there's tons of holes in research and a lot of good future directions that you will certainly, hopefully, be investigating in years to come, but that there's not a lot of guidance, especially if your patient can qualify for multiple biologic therapies. But trying to pick something that's the most practical for your patient, potentially being able to give it at home. And then know that there are data saying some patients fail initial biologic therapy but do really well on alternate agents. And then when we looked specifically at duration, I think, which is a question that comes up in clinical practice all the time, is that for the most part, all of the agents, as best we understand, are really safe and effective long-term. But that if patients want a trial going off of it, there do seem to be a subset of patients, both with omalizumab and with mepolizumab, which are really the only two that have been studied so far. There seem to be a subsegment of patients that maybe do okay off of biologic therapy for a period of time. And we really don't understand who those patients are yet. So in clinical practice, I think that translates to if your patient wants to go off of an agent, it's reasonable to try, but to expect that at some point they may need to go back on, and that you actually can successfully reintroduce your patient to the same biologic.